Hello everyone. Today we have another lecture of Principles of Surgery, and I'm happy to introduce our today's speaker, Dr. Kenney. Dr. Kenney is a general surgeon and he's a former chief of Brigham and Women's Faulkner Hospital. He was a chief there for 31 years, and today he will give us a talk on abdominal surgical incisions. Welcome, Dr. Kenney, and thank you very much for coming to give this talk. Thank you.
You're welcome. Can you all hear me?
Yes.
I guess so. All right. Well, very good. Thank you for signing up. Is it a 6 or 7 hour time difference? What time is it in Ukraine?
Hour.
Hmm?
It's 7 p.m. there.
So you're all very wide awake for the end of the day. I'm sure you put in a long, hard day. I'm going to talk to you a bit about some stuff that is interesting and perhaps becoming somewhat more old because we do so much stuff laparoscopically now. But what I like to teach the residents about here is different ways of approaching the abdomen. And as you can see by looking at me, I'm a pretty old guy. So although I was doing a lot of laparoscopic gallbladder surgery before I retired, I'm certainly not much more than that, and not anywhere near as good a laparoscopic surgeon as my colleagues. But one of the problems is that we're residents in the United States, and then suspect in the Ukraine, you're doing so much stuff laparoscopically now that you don't get a lot of exposure to how to approach the abdomen open. For you, those of you who are more senior, or those of you who have already finished your training, some of this stuff is going to be, I suspect, somewhat duplicative, and I apologize for that. But I think it's useful to go through anyway to get some idea of what we're talking about and what different incisions might be used for. So this is what we're going to talk about. I just have to make my screen go to the next slide. There we go. Starting off with a simple midline incision, and then we're going to start talking about things like the Coker, the subcostal incision, which is often used for gallbladder surgery, paramedian incision, and then some others. These are names that are used in the United States very commonly. And I think from our perspective, it makes life easy. But on the other hand, if you have questions, I know Ali said wait till the end, but if you have a question and I get going too fast or you don't understand something I said, please stop me, because I want you to be able to understand things. Any questions right now? Okay. All right, so the first one is pretty simple, the midline incision. And just how many of you have done midline abdominal incisions by now? Can I see? Well, some of you have turned your videos off, but if you've done it, you'll know what I'm talking about. It's a standard incision. It's one that we would say it might be called an all-purpose incision, obviously through skin, through fat, through the linea alba, and then into the peritoneum. We try very hard to teach our residents not to use the cautery to enter the peritoneum, because bowel can be underneath the peritoneum, and of course you can burn it with a cautery. Remember also that the linea alba is less well defined below the umbilicus. So that below the umbilicus, it's there, but it's sometimes harder to find it, and it certainly isn't as thick as it is above the umbilicus. It's what I called it as an all-purpose incision. It's used when the diagnosis may be in doubt, particularly in patients with trauma, where you have little time and not much time to do diagnostics beforehand. In a patient with a perforated viscus, perforated ulcer, perforated diverticulitis, or a patient with an acute abdomen, where they come in with horrible abdominal findings and sepsis, you resuscitate them and you go to the OR, you don't know what you're going after. Now, that isn't common these days, and you know, I don't know how available CT scanning is in the Ukraine. In the United States, there's a CT scanner on every corner, so most of the time there's a pretty good idea about what you're going after, but not always, and certainly not in trauma when there may not be time to get a scan. You need a midline incision because it allows you access to essentially the entire abdominal cavity, and it's rapid. You can get into the abdomen very quickly, especially in patients who have massive bleeding. It has some disadvantages. It hurts. It can be very painful postoperatively. FRSD stands for functional residual capacity. So there's pretty good data that goes back many years that a midline incision does impair patient's ventilation postoperatively just because of the pain. It's also, takes a while to close it. You have to close very precisely. You want to avoid the possibility of incisional hernias. And because of that, you need to be very careful about how you place your sutures. So when you close it, remember that the only strength layer in the closure is the linea alba itself. So we would tend to use an O size or even a larger suture. Nowadays, the peritoneum is not generally closed separately. There's no strength in it. If you have the ability and you want to take the time, you can do it, but it doesn't really add any strength to the closure. The choice of the suture is sort of dependent upon the senior surgeon in the room. Generally speaking, for elderly patients, I would choose a permanent suture made of nylon or polypropylene, usually of a number 1 or even a number 2 size. But the major advance in the last probably 5 or 6 years has been a thing in the United States called the stitch trial, which tried to cut back on the incidence of incisional hernias. And I suspect all of you have had a chance to operate on an incisional hernia by now. It is probably the one area there where laparoscopic approaches make sense, because these incisions do get hernias. The stitch trial, which I mentioned at the bottom of this slide, basically said when you close, you need very small bites in the fascia, only a 0.5 centimeters back from the cut edge, which still doesn't seem like enough to me, and only a 0.5 centimeter advance. So that's a lot of suturing, a lot of different points where the fascia is being held together. The key is to resist the temptation to take a huge bite and go all the way through the rectus, anterior and posterior rectus sheaths, and the rectus muscle, because by doing so, among other things, you will be cutting off blood supply to the fascia. And of course, as you all know, when you cut off blood supply, it isn't going to heal. And that may, in fact, be why patients were getting incisional hernias. So the stitch trial is an important one to keep in mind, because it does tell you that small bites, it's tedious to close, particularly if these are long incisions. But it does seem to have a good effect on diminishing the chance of incisional hernia after the surgery. So that's the midline. And as I said, it's a common incision. It's very useful. It allows you to get pretty much anywhere in the abdominal cavity. And, particularly for major vascular problems, like, for instance, a ruptured aortic aneurysm, you would need an incision essentially from the xiphoid to the pubis to get adequate exposure. So it can be very long. The next one is the so-called Coker incision, named after, of course, Theodore Coker, who has a lot of things named after him: the Coker maneuver, the Coker clamp. The Coker incision is used on the right side primarily for open cholecystectomy. You can do it on the left side, and it can be used for splenectomy. And in some cases, you can extend it on either side into what's called a chevron, so that you can essentially make one on either side and have them meet in the middle. That some surgeons prefer that for pancreatic surgery, for example. The key issue is it is parallel to the costal margin on the right side or left, and you want to make sure that you've got 2 finger breadths below the ribs when you make that incision. I put on this slide that you have to consider this when you're choosing your port sites for laparoscopic cholecystectomy. Why does that matter? Well, in those patients where you need to convert from the laparoscopic to the open surgery, you're going to make a Coker incision. Most surgeons are going to want to use the port sites already. They're going to use them and incorporate them into the incision. What I would often tell my residents is mark out where the Coker incision would be before you put any gas, before you insufflate the abdomen. The reason for that is that once you insufflate, everything stretches. And if you waited until then to mark out 2 finger breadths below the costal margin, when you desufflate, you discover that you're far too high on the fascia. So we always would mark out our 2 finger breadths, even though we weren't going to use it necessarily. We would mark out the incision and then make our port sites in that line, so that we could do an open incision if we had to. The layers of this incision, as those of you who've done it are probably aware, obviously skin, there's a very big amount of fat. Then you get to the anterior rectus sheath. You get to the rectus muscle, the internal oblique, and the transversus abdominis laterally, the posterior rectus sheath, and then the peritoneum, again, being very careful to go into the peritoneum with something non-cautery, all right? In the case where you've already got a port site hole, which you've put in, you can put your finger through that and elevate it. But the main thing is to make sure that you're not going to injure any bowel underneath it. The rectus muscle itself is actually divided. You can certainly do that with a cautery. Typically, when you make the incision in the anterior sheath, you can get your finger around behind the rectus muscle and elevate it. And then you can actually cauterize through that right down under your finger, which can get a little hot at times. I understand that. But the muscle is divided to make this thing work. And there's a picture here in this next slide of where you might place your retractors for this. This came out of a very good atlas that actually is now almost 30 years old from John Cameron, who was the chair of surgery at Johns Hopkins. And this just kind of shows you where you would place the retractors for exposure to get to the gallbladder. We use a device called a Bookwalter retractor, which is essentially a circular ring that goes around the incision, and then you can clamp these retractors onto the ring. You put a large retractor here to push the right colon down out of the way. You put a retractor here to lift the ribs. And then I should be pointing with my mouse, shouldn't I? The retractor here. And then typically a medium-sized malleable retractor here, and then a smaller one here. And that gives you a very good exposure of the gallbladder. Sometimes the exposure isn't as good as it is laparoscopically, let's be honest, but it is basically the reason you're doing this for the most part is in a patient where you cannot get the gallbladder out laparoscopically. So that is a standard Coker incision. And then just to complete what I was talking about before, how do we close it? Well, we close it in layers. The first layer typically is the peritoneum and the posterior sheath of the rectus, usually a running suture. Most surgeons would use an 0 or 2-0 suture of an absorbable type, either Dexon, polydextromethasone, or Dexton, or I'm blocking the name, or Vicryl in the United States. The second layer, the anterior sheath, is the strength layer. And again, for a young, healthy patient, we might use a larger diameter absorbable suture. For an older patient, we might use something permanent. Interestingly, you don't close the rectus. You don't try to put the ends together because it won't hold anyways. You can't really sew that muscle very well, and eventually it scars down and heals. The third layer, of course, is the skin. You can do this with a subcuticular suture, or you can do it with staples. I tend to use staples a lot if there is significant contamination because I worry about the wound becoming infected. And if you put a subcuticular suture in and the wound subsequently gets infected, as most of you know, I suspect the entire wound is going to open up if you take out a suture to drain the pus. Whereas with staples, you can take out 4 or 5 staples, the rest of the wound can stay closed, and you can treat the wound infection if it occurs. And as I said, you can leave the skin open and pack it if you find purulence and infection. So that might be something that's useful as well. This is a nice incision. It is somewhat painful, to be fair, but it's one of these things that people who do laparoscopic gallbladders, you're just very reluctant to open the patient's abdomen because they want to avoid this incision. A month later, the patient isn't going to know the difference. And frankly, they're going to be much happier with you that you chose to do the open surgery and not cause an injury to the bile duct or the gallbladder that would make things much more difficult. So I would encourage you, if you haven't done one of these, to sort of investigate it a bit in the situation where you need it. And that is, as I said, when you can't open the abdomen or you can't do the operation laparoscopically. This is one that most people don't know about very much. This is called a perimedian incision. And it's similar to the midline, but as you can see, you'll see in a second from a diagram, it is off one side or the other. So it goes down, you decide where the midline is, and then you go 3 to 4 centimeters out to one side or the other. Make your incision through the skin and subcutaneous fat down to the anterior rectus sheath. not the linea alba, but the anterior rectus sheath, and then you divide that vertically to expose the rectus muscle. The rectus is then retracted laterally, maintaining its blood supply and not dividing it. In front of you then is the posterior rectus sheath, which again, you can enter, and most of the time the peritoneum is right behind that, so you carefully go through that, you go through the peritoneum, and now you're in the peritoneal cavity. This can be used when more lateral access is desired, if you're going to do a right or left colectomy, for example. It's not used very much in the United States anywhere these days because it probably isn't that necessary, and you can get pretty much the same exposure through a midline. But you may run across a patient from time to time who's had this incision done for some other purpose. And here's the diagram I was talking about. So you can see here in the middle, this is the linea alba where you would make a midline incision. The perimedian incision on one side or the other, as you can see, is through both layers of the rectus sheath, pushing the rectus out laterally and then going into the peritoneum that way. It does have some advantages in terms of closure because you actually have two strength layers to close. You can close you can close them separately. Whether that translates into a lower incisional hernia rate or not is perhaps open to question. But when you think about the closure, the posterior sheath and peritoneum, again, usually an O or 2O absorbable suture, the rectus muscle then comes over back into its usual anatomic position, and then the anterior rectus sheath, again, absorbable, fairly sizable sutures, O, maybe a 2O, but absorbable or permanent depending upon the patient's health status. And then again, the skin can be closed in whichever fashion you think is appropriate. I doubt you're going to use this very often, but I wanted you to know about it simply because it does offer an option, particularly in a patient, if you're going to operate on them. I've had a patient, for example, who had a right colon cancer, and she was not healthy, and she had a huge incisional hernia in the midline that I wanted to avoid. I didn't want to try to deal with it at the same setting as the colon cancer because I didn't want to take a chance of infecting a mesh. So we made a perimedian incision and went in and got the cancer out, didn't touch the hernia, and then came back on a different day to fix the hernia. So there are some options that might be useful, or it might be useful, but again, pretty uncommonly used. This is one I'm sure you've all done, unless the only appendectomies you've done are laparoscopic. This is called a McBurney incision, which is used most commonly for open appendectomy. And again, nowadays, laparoscopic appendectomy is probably 88 to 85% of the, if not more, of the surgery for the appendix. But it's an oblique incision. It's fairly small. It begins at McBurney's point, which is about 2/3 of the distance from the umbilicus to the anterior superior iliac spine. Now, there's an important point here, and that is that if a CAT scan has already been done and has made the diagnosis of appendicitis, you might find that this incision's in the wrong place where I just described it. You might find it's more useful to go higher or lower because you want to obviously make the incision right over the appendix. And that's one of the uses of the preoperative CAT scan. I personally, in the United States, I think we do CAT scans too much, frankly, and you're all thinking, oh, he's an old guy, which is true. But, you know, the bottom line is that if we just go based on history alone, particularly in a male patient, you know, we're going to know pretty much what's wrong with the patient. So do they need a CAT scan? I'm not sure that's true. In females, it's a little more difficult because of the possibility of ovarian disease, but this is all sort of a side comment. But the McBurney incision goes back many, many, nearly decades. And it's a muscle splitting incision. So basically, after you get through the skin and the fat, you incise the external oblique aponeurosis in the direction of your incision. And then you get down to the next layer where you actually split the muscles with a Kelly clamp. So you spread them bluntly, and then you can put your finger in and open up and make the hole bigger. And then, as you can see in the slide here, you can elevate the peritoneum and make a small nick and avoid the bowel. And I keep saying that, I know, but having been through this sometimes with people who use a cautery to get in, you don't want to cause injury to the underlying bowel, so if you can avoid it. So carefully opening a peritoneum, and that allows you, hopefully, to come right down on the appendix just behind this. Sometimes it takes a bit of work to find it, the appendix, and you can put your finger in and find it and help deliver it up into the wound and do the appendectomy that way. Some people would actually use a low midline incision for appendicitis as well, but those are in patients where you have very complicated big phlegmons, big collections of edematous tissue, or rarely even an abscess. So that might even be a better incision. But this is for garden variety, straightforward appendicitis. And then the closure, pretty much like we've already done, you close the peritoneum. Now here, I like to close it not because it has any strength, because it doesn't, but it does keep the bowel out of the way as you're going to the next couple of layers. Sometimes we'll put a few interrupted sutures just to bring the muscles together, not expecting them to stay that way, but it closes up some of the surgical dead space. The third layer would be the external oblique, and this again is the strength layer of the closure, usually either a 2O or an O suture, usually here absorbable, so that we're not too worried about this thing. We're not too worried about the patients not healing, because most of the time they're young. And then, as I say, with the skin, I would usually use staples here because you have a contaminated field when you do an appendectomy. So therefore, you run the risk of a wound infection. And for the same reason I talked about earlier, you would like to make sure that if you do get a wound infection, you can just take out one or two or three of those staples and drain the incision, and drain the pus out without having the entire wound open up. This is a variation, and it's essentially identical. It's called a Rocky Davis incision. It's more horizontal instead of oblique. The closure is identical. I've never really understood the difference in terms of, except that somebody wanted to get a procedure named after himself. So here they go. They say, oh, I'm going to change the angle from oblique to horizontal, name it after myself. Also the Lance incision. It's essentially the same as the McBurney. Now here's one that the gynecologists use. This is called a Phalansteel incision. What does that mean? Well, it's basically designed for non-oncologic gynecologic surgery. In other words, a hysterectomy. It gives a very good cosmetic result. It is a transverse incision in the skin just above the pubis, just above the pubic hairline, basically. And it really gives great exposure for benign, not malignant, for benign gynecologic disease. The incision, after you go through, and in fact, I'll go to the next slide, you'll see it better. The incision goes down through the skin and fat, and here are the rectus muscles running vertically. The key thing here is you've incised the fascia transversely, but the incision in the peritoneum is vertical, right? And then you put in appropriate retractors, and there are a variety of ones that can be used here, including the Bookwalter that I talked about a minute ago. But as well, you can there are Balfour retractors and other things you can use, or you can have a friendly medical student helping you. But this does give you, it comes right down on top of the uterus and the ovary. So for gynecologic surgery, this is a very nice incision, but not for malignant. Again, it's got to be really, because this does not give you adequate exposure for lymph node dissections or anything else, and you wouldn't want to use it for that purpose. Closure is pretty much straightforward. As I talked about earlier, the rectus sheaths are closed with a running suture, usually an O absorbable suture, and then the skin can be closed either way. Remember that hysterectomy is a class, what we would call a class 2 wound. You're entering into an infected space, so there is always a potential for wound infection, as there is in any other wound. So I tend to use staples in this setting, but I don't do a lot of hysterectomies anymore. I haven't in years. Gynecologists have their own choices. Now, on a couple of things, we'll just talk about groin hernias. And again, because many hernias are now being done laparoscopically, this isn't as commonly done as it used to be. This is the kind of surgery that a first year or a second year resident would do a lot of, and they still do. I mean, probably 50%, maybe a bit less of the hernias in the United States are done with open surgery. This is a standard kind of incision, which is parallel to the inguinal ligament, usually a little bit above it. I say to the residents, you always would start immediately at the corner of the palpable pubic bone, and then you carry it out laterally to a point just below the anterior superior iliac spine. Key here is to make it long enough. One of the mistakes that people make is they try to do this with a very small incision, and you really can't get adequate exposure of what you have to repair for the hernia by doing that. So whenever I get called into a case and they're having trouble, it's usually because the incision isn't long enough. The skin and fat are incised down to the external oblique, which at this level has kind of curled around the spermatic cord, and that then gets split, and the cord is elevated up out of the canal, and there it should be the hernia, either a direct hernia or indirect that has to be dissected from the cord itself. And then you close in reverse order. Basically, after the hernia is repaired, that's done. The cord goes back into the canal, check for bleeding, obviously, and then you close the external oblique upon urosis over the cord. And then there's a layer called Scarpa's fascia, which can be closed with smaller, like 3/0 sutures, and then the skin. Here, I would often use a subcuticular suture because you're not entering an infected space. And in fact, closing the skin up tighter here probably is a good thing, I think, because you're right next to the groin. How about an umbilical hernia? This is a common problem, the second most common hernia after inguinals. For the most part, we're going to use an infraumbilical curvilinear transverse incision. We can use a supraumbilical if the hernia tends to be above it, the umbilicus, and I'll show you the next slide of what that looks like. After the skin incision, the hernia mass is often immediately encountered. And so you have to be a little careful when you're making this incision because you don't want to go into the hernia itself if you can avoid it. Sometimes it has bowel in it. I know I keep saying that again and again and again, but you want to try to avoid any of these entries into bowel in particular because could cause a problem. You don't want to have to be repairing bowel in the middle of putting a hernia together. You have to circumferentially dissect the hernia mass off of the undersurface of the umbilicus, and that sometimes is difficult. And then after the repair, whether it's done primarily with sutures or whether you put in a piece of mesh, you have to close it back in layers, and then the stalk of the umbilicus is tacked down to the fascia to recreate the umbilicus going into the abdomen. So here's what it looks like. In this case, this is an infraumbilical incision. But again, there's nothing that says you have to use this. If it looks like the hernia is above the umbilicus, for the most part, you can make a transverse incision and just be fine. So those are the incisions that I was going to talk about. And what I want to talk about now is shift a little bit to what you would do once you're there. How do you get intra-abdominal exposure? So we've already done the incision. We're in the abdomen. What do we do? Well, we want to make sure we have retractors. The table bolted retractors are very useful, and they save a lot of wear and tear on the junior residents and medical students. So you want to be able to pull the abdomen apart. Obviously, your anesthesiologist has given the patient a muscle relaxant to make that happen. We need to understand how to eviscerate the patient, and that means particularly for retroperitoneal trauma or retroperitoneal tumors or whatever, you need to be able to pull the entire bowel up out of the abdomen so you can get a better look at the retroperitoneum. This is hard to do, obviously, in patients who've had prior surgery because they have adhesions. But those are things that you have to worry about once you get there so you can see the retroperitoneum. Some people actually, particularly for the vascular cases, to try to keep the bowel warm and moist, they'll put it inside a plastic bag, literally, which you can bring to the field and pull the bowel up out of the abdominal cavity. You can't do it with the colon, obviously, but if you can get the small bowel out of the way, it makes some sense. Learn how to pack. Packing is very important with a large Miculitz pad. The large retractors that can bolt to the Bookwalter retractor, the curved blades, can help pack things out of the way. And take some time. This is really basically the most important part of open surgery once you get into the abdomen, is how to get the exposure. I've often said to my residents that surgery is about, 90% of it is exposure, easily. It's 5% skill, and the rest is just luck, blind luck. But the bottom line is getting exposure, packing, etc., makes a big difference in terms of exposure, of being able to work. Then there are various named maneuvers inside the abdomen, which will help us with exposure as well. There's a thing called the Coker maneuver. There's something else Coker is named after. And what does that mean? Well, I'll show you on the next slide. That is being able to get behind the duodenum. Remember that the duodenum in its sort of second here and third portion is a retroperitoneal structure. Peritoneum reflects off of the duodenum onto the abdominal wall. And to free it up, you have to lift that peritoneum up and incise it, and then get your fingers behind the duodenum and free up the pancreas and the duodenum as well. There are very, very few small vessels here. There's really no major vessel that you have to worry about. And once you do that, you can get to the retroperitoneum. You can see the bile duct, which is right here. You can see there's the vena cava. I mean, there's a whole a number of things that that's very useful for. And freeing it up also takes some of the tension off the duodenum if you have to work on the common bile duct. If you're trying to do something on the stomach, like repair duodenal ulcer, for example, taking some of the tension off by doing a Coker maneuver makes sense. This is another one called the Cattell-Brash maneuver, which basically is a much more extended version of the Coker. This is designed to get you to the retroperitoneum again, and you can take down the entire, that's the wrong picture, here it is, I'm sorry, I had it out of order. You can take down the entire right colon and free this all up. So what you're looking at here is the vena cava, the aorta, the kidney, the adrenal. All of this basically started out with a central Coker maneuver, but by doing further incision of that peritoneum on the lateral side of the right colon, you're able to free up the entire right colon to look at the retroperitoneum. This isn't done very often, but it does give you this incredible exposure of all the major vessels and the ureters, etc., in the retroperitoneum. The Maddox maneuver, which I suspect many of you have heard of, was popularized by Kenneth Maddox, who is a trauma surgeon in the United States, in Texas. And he basically was talking about the same thing on the other sides. In other words, you go down, you have to free up the spleen. And this isn't easy because the spleen does not like to have itself fooled around with. Then you take down the left colon and free this all up, and this gives you access to the left retroperitoneum in patients where there might be major hemorrhage. So this is and it takes some time, which means you have to be very precise about how you're doing this, because you do obviously need some degree of speed. But if you look at this cross section here, you can see how much has been freed up to gain access primarily to the left side of the retroperitoneum. That's the Maddox maneuver, all right? And then finally, the Pringle maneuver, named after Dr. Pringle, whose picture is there. This is a setting where you have a liver injury, and you have bleeding coming from the liver. You're not sure where it's coming from. The worst thing we can think of is to have bleeding from a retrohepatic vena cava injury. Those have a very, very high mortality. Those are seen with major decelerating trauma where the liver has essentially been torn off of the vena cava. Hopefully you'll never have to see one of those. The Pringle maneuver really doesn't help with that. It helps when you have arterial or portal venous bleeding coming from a fracture in the liver. And you can see the operator's hand here goes through the foramen of Winslow, or it's called the epiploic foramen. And in front of him or her is the portal vein, the hepatic artery, and the common duct. The Pringle maneuver is nothing more than essentially clamping across all those structures. And you can do it with a vascular clamp. What that does is it stops all arterial and venous and inflow into the liver, and hopefully will stop some of the bleeding. If it doesn't, if the bleeding still continues, then you may have this retrohepatic caval injury that I mentioned a minute ago. But most of the time, this will allow you to get control of the hemorrhage, allow the anesthesiologist to catch up because they're pouring blood into these patients as they bleed, and that allows the anesthesiologist to catch up and gives you a chance to reconnoiter a bit and see where you think the bleeding may be coming from that's coming out of the liver. So this is, again, a maneuver largely used in trauma situations, but something that might be very, very useful for you going forward. Now, I think that's my last slide. I deliberately left a fair amount of time for you guys to have questions, and I see about 4 of you are still online there. So what questions might you have?
Thank you very much, Dr. Kenney. We have question from Dr. Boyarsky, please, but please ask one question per person, okay? Thank you.
Thank you very much for the great lecture. My question, do you suture the wound the same way for elective and for emergency operations? And do you use subcutaneous fat?
I don't close the subcutaneous fat generally because it doesn't really have any holding power. And by putting a suture in it, you just increase the likelihood of an infection. For trauma versus elective or for any emergency, I think probably you would use the same, you might use a different material, but you close it the same way. For example, if I had someone with major sepsis, I might not use a absorbable suture. I might use a permanent suture instead. The technique is the same, basically. Part of the problem, of course, with what I was talking about in the beginning of these very, very minor, small bites and small sutures, it takes a long time to do it. So you may have to make a decision saying, look, if this patient's unstable after a trauma surgery or after, have to go a little faster. You may want to do more, fewer bites, bigger bites, and get the case done with. But I think it's important to keep that in mind. You have to make a judgment depending upon how the patient is doing.
Thank you, Dr. Kenney. Next question from Dr. Smolar.
Good evening. Thank you for your great lecture. My question is there any sense for restoring fascias after exposure maneuvers, such as restoring Tolt's fascia after cuttle brush maneuver, and so on? For example, in elective surgery.
Oh, you mean, are you asking, do you try to sew them back together again, the fascia?
Yeah.
Yeah, not really. I mean, it's going to go back down there anyway. That's where it wants to live. It will get quite adhesed pretty quickly. So adhesions are going to form. And that what you're cutting to free that up in the first place is just very thin peritoneum. So it's very unlikely that the suture would even hold, to be perfectly honest with you. It would just take more time than it's worth. So generally speaking, for either of those maneuvers, you would just, once you're done with whatever you have to be doing in the retroperitoneum, you'd let the thing fall back in place. And there's no real sense in trying to suture it together again. I've never heard of anybody having like a volvulus or anything like that after this. I don't think it's worth doing.
Okay, thank you.
Thank you. Next question from Dr. Lisecka.
Good evening. Thank you so much for a great lecture. And my question is, if you got a patient with post-operative hernia and a huge hypertrophic or keloid scar, what type of incision do you prefer and what type of suture material do you use?
Well, that's a great question. There's a lot of elements to it. You said you have a big hypertrophic keloid as well. Is that what you said?
Yes, yes.
Yeah. So the keloid obviously is something we have little control of, whereas as surgeons, some people believe that injecting steroids into it as you close makes some sense. In patients like that, or I've had a keloid, I just excise it and tell the patient it's likely to come back. As far as the hernia itself is concerned, a lot of it depends exactly on how big the thing is. We use a lot of mesh in the United States. We may actually use more than we need. The other thing that has become very popular in the United States recently, that's probably being done too much, is a technique called component separation, which you may have heard of, where you actually can incise the external oblique aponeurosis laterally, so the entire midline will come together. But that's probably being overused. So for most hernias, if you look at the diameter of the hernia defect itself, so probably 4 or 5 centimeters is the upper limit of what you might try to close by itself. Most of the time, I would put some kind of an underlay mesh in, either a polypropylene mesh, or there are various meshes that are coated in the back so they can be in contact with the bowel. And then you put them in with sort of interrupted sutures around the circumference of the mesh. And they go vertically. It's essentially a vertical mattress suture through the mesh, or through the patient, through the mesh, and back up through the patient. Even that is not a perfect closure. I mean, the incidence of recurrence is significant, and that's where patient selection becomes an issue. In the United States, or at least most surgeons, for example, if a patient is a smoker, they won't even operate on the patient because the incidence of recurrence of the hernia is so high in patients who smoke. Diabetes also contributes, as does vascular disease, but smoking itself is probably the single biggest contraindication to repair. For small hernias, though, I think a primary closure, usually using a permanent suture in the setting of a hernia, would make the most sense. And then for the larger hernias, certainly 4 or 5 centimeters in diameter, we would use an underlay piece of mesh. For very large hernias, that's where we might consider a component separation, which allows us to get the midline together, put a piece of mesh in underneath the rectus muscles. It's probably being overused because everybody thinks I'm looking for the way to make hernias, stay fixed forever. It probably doesn't exist.
And how we can save the cosmetic results, because patients always ask about cosmetic results.
Yeah, it's hard with a keloid forming patient. As I said, you can talk to your plastic surgery colleagues and they're going to look at you and say, I don't know. They're going to say the same thing. As I said, injecting this, some people believe injecting the steroid into the skin will help. There's a steroid called Kenney, and I don't remember the generic name of that, but I get a little nervous about putting steroids into any wound when I'm worried about infection. Of course, the biggest single complication, the worst complication you can have putting in mesh is an infection, because oftentimes the mesh has to come out to treat it, and that's awful. Then there are certain other meshes you can put in, but they have limits. So steroids in the wound, am I worried about infection? Yeah, a little bit. I just tell the patient, quite frankly, Sophia, that you may get another one. There isn't much we can do about keloid formation. In the United States, it's more common in African-American patients. Some patients of Northern European heritage have them. They're a very, very nasty problem. And I don't think that our plastic surgery colleagues have a good answer either.
Thank you so much.
Thanks, Dr. Kenney. Next question from Dr. Nozrin, please.
Thank you for the lecture. What do you think about using a prophylactic mesh with the patient? If you operate on a patient who doesn't have hernia, but you use a prophylactic mesh in the patient have increased risk?
Yeah, that's a great question. You have to look, first of all, why you operated in the first place. So if you operated for some type of perforated viscus, or in any patient where there's intra-abdominal sepsis, I'd say absolutely not. But if you operate on a patient, and you have not any intra-abdominal contamination, if the fascia is very weak, if the patient is poorly nourished, there might be an indication for it. To be honest, the complications that come with the use of mesh may outweigh the benefits in most cases. So generally speaking, we would not do it unless we have a very, very, very weak fascia. We have a patient who's very distended and we can't get them together. What's happening a lot in the United States, of course, is they choose an open abdomen approach where they'll leave the abdomen open deliberately. And then once distension, once edema goes down, they'll go back in 2 or 3 days and do a primary closure, sometimes using mesh there. But generally speaking, I don't know if I can think of a time when I actually put mesh in on a prophylactic basis. It's pretty uncommon.
Thanks, Dr. Kenney. Next question from Dr. Черевної, please.
Good evening. Thank you for a lecture. The question is, would you advise if we have a patient with an incisional hernia, especially a large one, and the patient is undergoing surgery due to some other reasons? For example, it is oncological procedure, or another example, if it is an emergency surgery, for example, perforated ulcer or some other potentially infectious situation. Would you place a mesh on the hernia place, or would you only approximate and suture the fascia in the case of an elective major abdominal surgery, and in the other case of emergency surgery with the potential infectious complications?
Sure. Well, there's a lot of answers. The way to answer that question. I mean, the hernia, if it's very large, as you suggested, obviously you're not going to get it back together again. There are biologic meshes that are out there that can be used in that setting. They have not, when they were first introduced, they were supposed to be, this fixes everything, right? This is what you need for everything. It turns out they fail. They can actually weaken and can dissolve over time. There's a new one called Phasix. I'm not sure what the generic name is. It's extraordinarily expensive, but some of my colleagues, particularly over at the Brigham, are very much in favor of it for just the kind of setting you described. A hernia that if you were going to fix the hernia by itself and you didn't have, intra-abdominal infection, you wouldn't dream of using it. But in a setting where you've had to take care of a perforated ulcer or perforated diverticulitis or some kind of injury to bowel where there is free contamination, you're going to have to put some mesh in. There are surgeons who will use other types of mesh and claim they can get away with it, but you take an enormous risk, and the risk, of course, is of breakdown of fascia, that the thing will not hold, and seeding of the mesh itself, particularly with things like methicillin-resistant Staphylococcus aureus. So the short answer to your question is, yeah, you've got to get the bowel back in, you've got to get it closed somehow, and the biologic meshes, things like Alloderm and Stratus, this phasic stuff, again, they're very expensive. If you don't have that available to you, you can put regular mesh. Two evils, I guess, if you're still for infection. There's no easy answer to that. I mean, if you can make an incision away from the hernia, like I talked to you about in that patient I operated on, that's not so bad either. And again, you might even consider in an emergency situation an open abdomen approach where you fix what's wrong. That is, you fix the ulcer or you resect the diverticulitis or whatever, and then leave it open and then come back to fight again another day. There's only so much time you can buy with that, though. I mean, it only is going to good you maybe 2 or 3 days, and by then the contamination isn't necessarily getting better. So it's a hard question. It's a hard question to answer and hard to deal with. You have to make an individual judgment about each patient.
Thank you.
Thank you, Dr. Kenney. Next question from Dr. El Kafarna, please.
Thank you, Dr. Kenney, for the lecture. I have a practical question. Today we had a patient 80 plus years old. She had an incarcerated femoral hernia, 5 days. And when we opened the hernial sac, we found out that the bowel loop, the small intestine, was actually gangrenous. And we couldn't actually repair it. What should we do in this case? The senior surgeon, he did like a vertical cephalad incision from perpendicular to the inguinal ligament.
Right. So let me understand, because you made a groin incision first. Is that what you did?
Yes. Yes.
And then you couldn't repair it through that incision. Is that what you're saying?
Yes.
And then the senior surgeon made a separate second vertical incision?
Yes, exactly.
Yeah, and the purpose of that was to get into the abdominal cavity. Is that right?
Yeah, that's correct.
Yeah. And at that point, were you able to remove the dead bowel?
Yes, the patient was unstable. We had to resect the bowel, and we just closed the wound, and we had to take the patient to the ICU. She had spinal anesthesia. Do you think we should have done a midline laparotomy?
Yeah, I mean, it sounds like you didn't put the bowel back together again. Is that correct? You did not do it in
That's correct.
All right, so you just stapled off the 2 ends of the bowel, and you're going to have to go back tomorrow or something like that to do the anastomosis?
Yes, exactly.
Yeah. In the setting where you're doing a femoral hernia, it's nice if you can get the bowel freed up enough to do an anastomosis there. It sounds like that wasn't a possibility here, or you couldn't get it to go back in again. So most of the time, yes, we would probably do a midline abdominal incision instead. That we wouldn't necessarily extend, and I may not be understanding you, but we wouldn't extend the groin incision up. We would make a midline incision and allow us to sort of reduce the bowel back up into the peritoneal cavity that way, and then resect, and then maybe or maybe not do the anastomosis. I mean, in a setting where the patient's unstable, yeah, it makes sense to just stop and then go back again the next day. But for the most part, if you can't get the bowel to go back up into the abdominal cavity after you've done the resection, then a midline abdominal incision is the right answer.
Thank you.
Thank you, Dr. Kenney. Next question from Dr. Mikhalnyuk, please.
Good evening. Thank you for the great lecture. My question is, maybe you got some tips and tricks how to actually get into frozen abdomen.
I'm sorry, how to what, Bohan? How to close?
How to get into frozen abdomen.
A frozen abdomen. The best tip is to find another surgeon. Let him or her do it. Now, frozen abdomen, for those of you who haven't encountered one, is a patient who has multiple adhesions, usually from prior surgery or hernia repairs, etc. And typically you need to go after something that's deep in the abdomen. Is this what you're talking about, on where you have a lot of adhesions from prior surgery?
Yeah.
Yeah. Sometimes seen also in patients with metastatic intra-abdominal cancers, where there are multiple cancer deposits. There's no easy way to get around it. You have to basically very, very carefully, it takes a long, long time, dissect with the scissors and a forceps. I don't use a lot of cautery. There's no easy way to get in, because if you rush it and you get impatient, you're going to tear bowel, and then you're going to have an even worse problem, because you're going to have the bowel contents leaking into the peritoneal cavity. There's really no great tips. I mean, it's basically your assistant on the other side of the table is going to take a couple of, usually Coker clamps, elevate up the fascia, and then you can get underneath it and then carefully begin to get the abdominal cavity freed off of the abdominal wall. In other words, you're underneath peritoneum like this. You're going underneath it with your scissors, carefully visualizing, getting your fingers in so you can actually feel the edge of the bowel. But as you may have known or have had experience with, this takes a long, long time. And there's no easy trick to getting into it. There's no easy way to free it up. It'd be nice if we could just pour some solution in there and dissolve everything, but unfortunately it doesn't work that way.
Thank you, Dr. Kenney. We have a question from Dr. Ivanchenko, please.
Hello?
Sorry, we cannot hear you. While we're waiting, Dr. Kenney, we have a question on chat. Dr. Melnick is asking, do you perform subcutaneous adipose tissue stitching in obese patients?
It's tempting to do it because you think you're closing up the dead space, and maybe very rarely, but not very often. I've never been impressed that it makes much difference.
Mm-hmm.
If you've got a huge fat pad that's 2 or 3 or 4 inches, thick, you might try bringing it together. It takes some tension off of the skin. I've never been impressed it makes that much difference. So again, that's sort of personal preference in some respects for the surgeon, but I've not been impressed it makes much difference.
Thanks. And he's also asking, are there any effective methods to prevent seroma after wound closure?
Not that we've seen. I mean, some people like to drain wounds, but the drain, as you probably know, is like a two-way street, because it might allow fluid to come out, but can also allow bacteria to go in. Even a closed suction drain, and very few people use those. I mean, in theory, you could do it, but that in and of itself is still also going to allow bacteria to get into the wound, even though it's a closed suction drain. That incision where the drain comes out can still allow entry. So, short answer is not really. I'd much rather deal with seroma if it was not infected later on and aspirate it if I had to. But we don't see them that often, even in these very, very obese patients. So I would not generally try to prevent it from forming, for the most part.
Thanks, Dr. Kenney. And we have a question from Dr. Chervonochenko, please.
What would you advise for an incisions like J-shaped or L-shaped or T-shaped laparotomies done in liver surgery or in surgery of big sarcomas when you have part of the incision midline and part of the incision is transverse? How would you close the incision? Would you close the transverse part in 2 layers and then the midline in 1 layer, or maybe you have some tips on that?
No, I probably would do what you just described. You would do the transverse or the oblique thing first. The weakness in that is going to be where they come together at the point. In other words, you've got a oblique incision. Look at my fingers. You've got this oblique incision here. You close that up, then you've got a vertical midline. The weakness is going to be right there, where the two come together, and that's the chance of an incisional hernia there is pretty high. That's one of the issues, by the way, with the chevron incision, bringing it together like this. We talked about that at the beginning. But an incision like that, as you said, used for liver surgery, used for better access, or you could even think of it in reverse if you had a right upper quadrant incision and you had to go vertically up into a sternotomy or something like that. Those are all areas of weakness. But yes, to your question, I would close up the oblique part first, just in layers, and being very careful, not taking massive bites if you have the time, and then close the midline. Some people might even argue putting in what are called retention sutures, which, as you probably know, are huge, full thickness sutures through the entire abdominal wall. Those are, talk about cosmetics, those are like the worst. They're very painful, and the reality is they may not do that much good. So being careful, being precise, I think, is the real key to closing a wound like that.
Thank you.
Thank you, Dr. Kenney. And I think we have the last question from Dr. Ivanchenko on chat. What do you do when the abdomen cannot be closed? For example, when there is a large defect in abdominal wall.
Most of the time now, there are a variety of, there's a thing called an abthera, which I'm not sure what it is in Europe. It is a device which you actually implant. You don't try to close. You implant it and you cover it up and seal it to try to maintain the integrity of not losing fluids and aspirin into the free air. And then after a couple of days, you go back once the edema has gone down, and then you can try to successively close things together. Open packing of the abdominal cavity was popularized a number of years ago in trauma cases. And when it was revealed, it found that we were giving probably too much fluid when the patients were developing abdominal compartment syndrome. The intra-abdominal pressure was rising so high. One of the ways to avoid that is to give less fluid, perhaps, but if they need blood, they need fluid, they need it. And as you can imagine, that would create substantial edema in the abdominal cavity. When you close that together and it doesn't really want to be together, the intra-abdominal pressure rises, pulmonary pressure rises, ventilatory mechanics change, urine output drops. So leaving the abdomen open in that setting to allow the edema to go down, to allow things to improve, and then to go back in 2 or 3 days makes some sense. There are various ways to do it. You can take, if you haven't got the fancy abthera stuff I was talking about, you can actually take regular sheets of the plastic that we'll put down to make incisions. You can put some towels in between those, protect the bowel, cover it up. It's very tough patients to take care of from a nursing standpoint, but you can get them down and can get them closed eventually. It may require 2 or 3 changes, even taking back to the operating room. And again, you're going to risk incisional hernia no matter what. But the open abdomen, I think in the United States, I have a feeling it's actually being used too much, quite frankly, because people are worried about closing. But the right mix is someplace in between of what we're doing now, because we hear cases every week, and Ali can attest to this, in our mortality morbidity conference where they've used an open abdomen and something's gone wrong. So it can be done, but just be careful that you know why you're doing it, and just be careful that you're doing it the right way.
Thank you very much, Dr. Kenney, and I highly encourage our participants who wanted to ask questions but did not have opportunity to use our Heal UA mobile application And Dr. Kenney, we're also inviting you to this platform, and afterwards we would be happy to explain you how to get involved, and would be happy to have you in this platform. And so generally, as a rule, we invite all our speakers from this course to the platform, and already we see some communication there between the lecturers and students who did not have an opportunity to ask. And thank you very much, Dr. Kenney, for your time, for sharing your knowledge and wisdom with our Ukrainian colleagues. Very important topic, and Happy New Year.
Happy New Year to you all, and I admire you're all working very hard in difficult circumstances, so I admire what you're doing. We're going to talk again probably later on this spring, and a thing that I call bailouts. In other words, not about incisions and things, but situations where you might find yourself and what do I do now? A little bit of what we were just talking about. So we'll see you again, hopefully in a month or two.
See you, Dr. Kenney, and see you all. Thank you very much.
All right, my pleasure. Good luck to you all. Happy New Year.
Happy New Year.
Thank you. Bye-bye.
Bye-bye.
Thank you. Thank you.
Thank you.